You are frozen.
Frozen.
Okay.
Okay ya.
Delay
Delay sikit lah.
I see.
Dia takkan 100% je. Bila recall apa 5 factor dah sekarang. Okey. Lampu dia tak orang tak on terus. Speaker tidak ya, mic. Before okay. But okay.
Yeah. Very good morning to everybody. Selamat pagi. I'm Mr. Lim. I'm from the orthopedic department in Hospital Sultanah Maliha, previously known as Hospital Langkawi. Today I'll be talking about some common hand conditions which we often see in clinics and outpatient settings lah. I hope that after this CME, everyone will have some overview of the most common hand conditions. For doctors, I hope that everybody can make the correct diagnosis promptly, early, so that treatment can be started early. Because as we know, as for all kind of conditions, early treatment will lead to better outcome, right? Yeah. So that's our main objectives. Today I'll be covering a few very common hand conditions lah. From ganglion cysts, and I'll be talking about trigger fingers, carpal tunnel syndrome, which is so common. Some people will will be having it now, but they don't know they'll be having this problem. Decurvins, which is equally common. Hand conditions, which is very painful, very uncomfortable. So let's move on to the first one. Let's talk about ganglion cyst. What is this thing? Patients often get very, very anxious when they get this kind of lumps and bumps suddenly appearing in their head, previously beautiful hand. It's actually a very benign thing, non-malignant, is filled with mucin. It's a synovial cyst. It can be caused by microtrauma, mucoid degeneration, synovial herniation. Anything can cause it, but everything is benign. We can see that it is filled with clear fluids. Sometimes it can be from the tendon sheath as well, not only from the joint, because as we know, synovial joints, tendon sheath, they all have a synovial sheath, synovial membrane, so they can form ganglion cyst. Later we will talk about it. There's no true epithelial lining in ganglion cysts. They are all synovial cells only. Yeah. So, however benign it is very common and very nuisance, trouble to our patients, because it affects their cosmesis, sometimes pain. Almost 60-70% of people of the mass or lumps and bumps in the area of the hand and wrist is caused by ganglion cysts. And the location of them tells us a lot. The location of the lumps, it tells us a lot about the diagnosis, because they usually appears in a very, very specific area and very common area. They don't come out from all the joints. Only certain joints only they come out. Yeah. So the most common one is where? This one is the most common one, the dorsal carpal one, dorsal wrist. Okay. The dorsal wrist ganglion, up to 70%. They are from this, specifically from this SL joint, scapulonate joint, from the carpal bones. 20% of them are from the volar carpal. They are from different joint, STT joint, radial carpal joint. This is shown in the lower picture. This is a volar type, which is very near to the artery, as you can see. Yeah, volar one. And very rarely, not very rare, also 10%, volar in the retinacular, which is in the middle of the finger, you see? Volar side of the finger. They are from the tendon sheath. And least commonly is the also patient with the osteoarthritis. You see there are some deformities in the fingers. Sometimes you can find in the DIP joint, the distal interphalangeal joint. Hujung sini. Already there's a deformity. Now suddenly there's a small swelling there. That is ganglion cyst. So you see, it can be quite large and quite prominent, especially in very thin individuals. But they are usually asymptomatic, not painful, not troubling. Sometimes if it's too big, then you feel some uncomfortable when moving. But the main issue with the patients is cosmesis. Tak cantik ya? How do we diagnose it? So, from physical examination, gives us some clue. If you have a torch, it can be easily transilluminate. Macam satu, like a pearl under the skin. it lights up. And then with palpation, this is very well circumscribed. You can feel the edges very nicely. And you can easily move the skin on top of it. It's very smooth under the skin. It's not fixed to the skin, but it is fixed to the deep tissue because it's from the synovial joint. So you can see from the picture on the right lower, the ganglion cyst is kind of fixed to the lower structure. You can't really move it from the deep, but the skin on top easily slipping over. So this gives us some clue. Of course, we can order for ultrasound. Our dear colleagues will. Sometimes you need their help to determine that whether there's some arteries, especially those are from the volar one. Volar, we must be very careful. Volar ones, you see in this picture, in this particular case, the artery is like hugging the ganglion cyst. So it will be very, very dangerous for us to do aspiration for this kind of ganglion cyst. So what is the treatment, general treatment for ganglion cyst? We always observe first. Yes, we always reassure the patient that it is a benign condition. Bukan malignant, bukan cancer. Jangan risau. Especially in children. Often it occurs in adults, but sometimes children also we encounter. In pediatric patients, it is shown to be easily, it can be resolved most of the time in a year or two. So we observe first. If required, then there's a choice of aspiration. Like I said before, the volar aspect must be very careful because it's very near to the artery. So don't simply aspirate the volar ganglion cyst. But bear in mind that aspiration can provide temporary relief because you keluarkan dia punya the akar masih ada di sana. This is how we tell the patient because we didn't tie the stalk. Tempat dia keluar punya, kita tak tie lagi. So we aspirate, there is a possibility that it will come back. Higher recurrence, that's what we call. So the next option for the patient is surgical resection. Kita buat operation under LA most of the time. Sometimes in the volar ganglion, we might need GA. The indications is, like I say, in severe symptoms only. And because this is mainly a cosmetic problem, and if it really causes some neurovascular problem to the patient, if it's too near, the ganglion cyst is too near to the structure. For example, there was one case, just to share with you, a ganglion cyst in an uncommon place. It happened in a cubital tunnel. This is in a area where the ulnar nerve lies. Yes. So in the end, the ulnar nerves is compromised, very weak and claw hand. So during the surgery, ganglion cyst was found to be coming out from the elbow joint. So this is one of the indication for surgery. This is how it looks like intraoperatively. this very clear, like a pearl, like I say, clear fluid. Yeah? We have to go very carefully until the stalk or the akar, like you see. And sometimes we have to take out a portion of the capsule, yeah, to prevent recurrence. A special note on the DIP joint mucus cyst, the ganglion cyst in the DIP joint in the osteoarthritic patient. In this area, those osteophytes has to be taken out too, yeah, to prevent recurrence again. So everything we do surgically, we are trying to prevent recurrence and all sorts of other complications lah. Next, we go to trigger finger. Trigger finger, or when it happens in the thumb, we call trigger thumb. We have only 4 fingers and 1 thumb in a hand. This is usually caused by impingement. Impingement at which level? At A1 pulley. And it causes progressive pain and clicking and all this catching sensation, very uncomfortable until one point painful, non-functional for the patient. So where is A1? A1 pulley is located at our metacarpophalangeal joint, like shown in the picture in the upper right hand side. So it's been shown that it is associated with diabetic populations. There are few cases presented first as a trigger finger, means that they have no diabetes before this, but they have trigger finger. After that, we find out that patient has diabetes. But fret not all trigger fingers is diabetes. This is not diagnostic for diabetes. It is associated in 10% of diabetic population. Happens in female 50 years old more. Often in ring and long fingers are most commonly involved. The tendons, we have 2 tendons in each finger. Flexor digitorum profundus sometimes will have some pathological nodule. This nodule, as shown in the picture, prevents smooth gliding through the A1 pulley. But the main issue is still with the thickened A1 pulley. These pathological nodules sometimes happen. We find it intraoperatively. How do they present to us? Usually they come with pain, very painful and catching sensation, sometimes with a palpable nodule in the A1 pulley area. So if they are severe, they can be locked in the flexed position. Yeah, because when it's flexed, it goes through the tunnel and it couldn't extend because it's stuck in the A1 pulley. Yeah. So there are stages. First grade is just pain, tenderness. And if we pick up patients at this stage, means that we diagnose them at this stage and we do appropriate management with the physiotherapy and all the therapies. We start early. We might prevent the trigger finger from progressing, because trigger finger is a progressive pathology. If you don't deal with it, it will become more and more severe. Yeah. So if you deal with it early, you can get rid of it sometimes. Grade 2 is catching of the digit already. There will be some feeling of catching of the digit. Not smooth anymore. Grade 3, the digit is locked already in flex position. It cannot extend anymore. It cannot extend anymore. But then, if the patient will tell you, he will show it to you very nicely. Grade 3, passively correctable, can correct himself. In the most severe case, and we rarely seen in the Malaysian population, sometimes you encounter. But if it comes at a grade 4, when it is fixed and locked in the fixed flexion position and cannot be corrected, then we have some problem. Because contracture and finger stiffness will complicate the pathology. So what do? We can spleen the hand, modify activities that causes pain. We can give NSAIDs for painful fingers or painful thumbs. This is usually the first line of treatment, unless it's very severe type of trigger finger, grade 3, grade 4. A different story already because it's affecting the function. And the outcome could be quite well. Next is steroid injection. This is really not for the thumb, as the thumb is a little bit different from the other fingers. As you might notice, our thumb is 90 degrees in orientation to the other fingers. So the nerves and the arteries, they will rotate together with the thumb. And because of that, injections into the thumbs at the base could be detrimental, very dangerous to the nerves and the arteries. However, if done correctly in the fingers, it could lead to very good outcome. Next is operation. There are percutaneous and open methods. Percutaneous release of A1 pulley is done by using a needle with its sharp needle tip. So the sharp needle tip, we introduce it under local anesthesia in an angle. We make sure that it's not in the tendon. And we use the very sharp edge of the needle tip, to lift up and sever or cut the A1 pulley. Next is open release. Open release of A1 pulley is done under LA as well, usually. And in the picture at the left lower corner, you can see a open surgical site. And the white color structure, and the fiber you can see oriented transversely, those are the fibers of the A1 pulley. Usually in a trigger finger, you can see that it is very thick. So when we're doing the surgery, must be very careful, because just underneath the pulley is our tendons for the fingers. As you can see in the center lower picture, the blade of the sharp edge of the blade is facing upwards, in order to prevent injury to the tendons. And this is not a false alarm. this could happen, and it has happened before, that a tendon is cut inadvertently during the surgery. So the surgery has to be done in a very careful manner. As I said before, all surgeries, we are trying to minimize the complications. In this case, in trigger finger, in the thumb, we can see the nerves is directly obliquely going through over the A1 pulley area. So the nerves is at risk. And if you cut a wrong pulley, A2 or A4 pulley, if you cut the wrong one, bowstringing, causing more problem to the patient. And all sorts of wound complication can happen as well. Wound breakdown, tenderness, numbness, even finger stiffness because of slight tendon injuries during the procedure. Because the tendon is very, what we call manja structure. We cannot pinch it too hard. We cannot sever it with any sharp structures. Very, very easily become stiffness, fibrosis, and all sorts of things. Next, let's move on to the next common conditions that we always see in the clinic, carpal tunnel syndrome. There's a tunnel in our wrist. All the tendons and nerves going to the fingers pass through this tunnel. And on top of the tunnel, there's a roof. The roof is transverse carpal ligament, and sometimes it causes compression neuropathy. Most of the time it's idiopathic. No, it is caused by inflamed or pathologic synovium. And it could be caused by the repetitive motions. And sometimes you can find some, in odd cases, some rare cases, space-occupying lesions, such as in this case, long-standing gout. The gout not only in the subcutaneous or in the... So when the tendon is resected out, the whole tendon is almost transformed already. You cannot repair it back. Almost transformed into a gouty tophi. And the deposit is so much that it compresses on the very tiny and very Gaussian median nerve there, and causes a lot of problem to the patient. It's associated with some conditions, diabetes, hypothyroidism, mainly because it could be caused by increase of fluid inside the tunnel, rheumatoid arthritis, pregnancy, and gouty arthritis. They come with numbness and tingling sensation, getting more and more severe. In this very specific area, not in the little finger, they will present with radial means the lateral side, 3.5 digits. Some will even map to you, this is the area that I have numbness. The pain and the paresthesia, the feelings of needles, and all the semut, the feelings awaken them at night. So it troubles them at night. a lot of night symptoms. And on examination, the thenar muscle is atrophied in some of the long standing case. If they presented late, the thenar muscle will get atrophied because the median nerve supplied thenar muscles. And carpal tunnel syndrome, it's a clinical diagnosis. We perform a few tests to confirm it. The most sensitive is the Dukan's, the carpal tunnel compression test, the right lower side. We compress it for some time, and the patient will tell you the numbness reappears. Phelan test, when the wrist is flexed, our carpal tunnel space reduce dramatically. And like squeezing an orange, it increased the pressure so much. So for 60 seconds, as written in this book, but often you see, after a few seconds, he'll tell you to stop already because it's very, very uncomfortable. So this is a positive Phelan test. Thinner sign, we tap on the course of the median nerve along the carpal tunnel to see if there's any symptoms or not. So combine all the signs and symptoms, we diagnose carpal tunnel syndrome clinically. What do we do? What do we suggest to our patients? Of course, there's option of physiotherapy, doing nerve gliding exercise. Nerve wrist in the neutral position, making the fist. Wrist in the neutral position, extend finger and thumb. Extend the wrist and finger, extend your thumb. Turn it supinate. Turn it supinate facing you, the palm. And use the other hand to pull and stretch the thumb. These motions really stretch and help with some of our patients. And for patients who has nocturnal symptoms, nighttime symptoms, is troubling them a lot because during when you're sleeping, the position of the hand is sometimes in a flexed position or awkward position, and when we do that for a long time, the pressure increases and then the symptoms comes and wakes the patient up. So in these kind of cases, it's good to give a trial of spleen, a night spleen. Spleen it in a neutral position so that it don't get flexed or in awkward position. And avoid all the aggravating activities. Every patient has a different story to tell. Carpal tunnel release is what we can offer to our patient with carpal tunnel syndrome who has failed all the non-operative treatments. Unless they're in very severe case, it come with already like the case just now, the gouty tophi. So other than that, we always give a trial of non-operative treatment. If it fails, then we can perform the carpal tunnel release. Sometimes the carpal tunnel syndrome comes very acutely. Very acute means suddenly it becomes carpal tunnel syndrome. Only happens in trauma case. In trauma case, in this kind of hyperextended wrist injury, when the wrist is hyperextended, fall on the motor vehicle, very, very high energy, and the lunate, one of the bone in the carpal and the wrist joint, jump out. The red color one jumped out from the wrist and go and compress the median nerve. or in this very miserable case, we need to perform a carpal tunnel release as well. So the complications of a carpal tunnel syndrome, of a carpal tunnel release, also has to be explained to the patient, because the most common complication is incomplete release. The release of the carpal tunnel is incomplete, means the transverse carpal ligament is cut, maybe left a little bit of fiber there, belum habis potong. So it leads to a symptoms, persistent symptom, and worse still, thenar atrophy. We want to prevent this at all costs. Thenar atrophy. The blue arrow is showing the thenar muscle. This is our main muscle in one of the main muscle in our hand. Our hand function, 50% of them, of our hand function, is by our thumb. Opposition, it cannot be done by any other species, only in human. And 4 fingers is equal to 1 thumb. This is what my professor always tell me. So at all costs, we want to save the thumb. So when we see this thenar atrophy, we see this thenar atrophy in the clinic, we turn away and we cry first, slowly, because we are so sorry for the patient. We couldn't do anything for them, for this thenar atrophy. We can only release the carpal tunnel and hope for the best. Yes, but often it is not able to recover the power. Maybe a little bit, I'm not sure. But we want to try at all costs. Now we are talking about complication of surgery, to avoid injury to one of the branch in the, this is a branch of the median nerve that could potentially be injured during the surgery. There's another options available in hand centers, endoscopic carpal tunnel release. So only the small wound is required rather than a big wound, which sometimes cause some problem to the patient post-operatively. They have pain, they have numbness, they have CRPS sometimes after operation, which is horrible. So endoscopic carpal tunnel release is described, and you can see from the lower picture, one hand of the patient, left hand was done with the open procedure, and the right hand was done with the endoscopic method. Smaller wounds, better rehabilitation, faster rehabilitation, and return to work. However, there's no long-term outcome that suggests it is better than the open carpal tunnel release. And when we do open procedure, already there's some cases that involve incomplete division. So endoscopic release also will have this kind of problem, this kind of complications. Next, we'll be talking about decurvance tenosynovitis, the mummy's wrist. This is the radial-sided wrist pain. Radial-sided wrist pains in the lateral side of the wrist. Very painful condition. It happens in the first dorsal compartment. There are 6 compartments in the extensor tendons, and this is from the first dorsal compartments. First dorsal compartments ada APL, APB yang ada warnakan di sini. So this is the tendon that get inflamed and causes the patient's symptoms. The risk factor is overuse, golfers, racket sports, trauma, and in new mothers. So this is not a very suggestive way to lift the babies because it really strains the first dorsal compartment a lot. And it is gradually onset, radial-sided wrist pain, as I told. And the pain is exacerbated, increased by gripping and raising some objects. How do we confirm this diagnosis? Also a clinical diagnosis, we provocate the pain. Little bit lah, not too much. There are two maneuvers, very commonly described is finger stun. Finger stun is grasping the thumb and pull it in this way, not so hard as shown in the picture here. Very gently. Small pain, the patient feel already stopped. Yeah? It's very, very uncomfortable test, but a very important one to establish the diagnosis. So if you do one, you don't do the other lah, causing too much uncomfortable. Aschoff maneuver. The thumb is inside the fingers, grasping, and in the ulnar deviated motion, the patient tell you the pain is too much. Stop it. Yeah. How do we deal with decurvence? We always start with non-operative treatment. Reassure the patient. Give NSAIDs. If there's no contraindication, rest. This is easier said than done for mummies. Immobilization using splints of sorts. And if everything is not helping, steroid injections. Steroid and LA lah. Usually we give steroid and LA together into the first dorsal compartment. Yes, in the clinic, done in the clinic. However, the recurrence rate is very high, as we tell later. And if everything doesn't go well, then surgical release is indicated. We release the first dorsal compartment. Yeah, as shown in this cartoon here. The first dorsal compartment with APL and PB inside is released completely. This is indicated if there's failed non-operative treatment. So every surgery we offer to the patients, we must, and for sure, return inside the consent, inform about the possible complications. Radial nerve, the sensory branch of it. When the radial nerve comes to the end, when it reaches the wrist, it is already a sensory branch, but a very important one. Why? Because it goes right on top of the first dorsal compartment. When we do surgery, the nerve is just under the skin. If inadvertently injured, neuroma can form and it can cause more pain than the dequavin. So, must be very careful. This I always tell to the MOs and whoever doing the surgeries. And the most common one for dequavin tenosynovitis is recurrence, failure of decompression. As you can see in this picture, APL can have different sleeps. They can have 2 sleeps, 3 sleeps, 4 sleeps. So when we release one, we thought finish already. Mana tahu ada 2-3 lagi. So APL has got multi-sleeps. And EPB, on the other hand, has shown to be sometimes to have sub-shift. Dia bukan satu shift, ada sub-shift lagi. Sometimes, yeah, normal variation. So with this in mind, you understand that when we do injection, we do it blindly. Sometimes with ultrasound guided, but not many centers can do that. So even with ultrasound guided, you can miss the subshift, right? You can miss multi-sleep as well. So recurrence rate is very high. And complex regional pain syndrome. So my take-home message is very simple. Common things is still common. Ganglion cyst is the most common and benign hand mass. Trigger finger can sometimes resolve completely if the therapy is started early, if you recognize it early, at the first stage when it's still painful, just painful, no clicking. Carpal tunnel syndrome is a clinical diagnosis. And dequavance injection has higher failure rate. However, the most common hand condition in the year 2020 goes to the hand with germs. And I hope that this reminds everyone to cuci tangan selalu dengan hand sanitizer ataupun dengan sabun dan air. Terima kasih. Okay, thank you. Yeah. Yeah, for which condition?
Okay.
Yeah.
Oh tadi
Trigger finger ini trigger punya.
Tapi dalam ni tak ada kan bola.
Yeah.
Actually I have bola.
Yeah.
Cyst tu.
Ganglion ya. Tapi dia kalau dia tak kacau kita tak buat operation lah.
Tapi memang sakit betul.
Oh, kalau sakit boleh buatnya.
Tapi dia very near the artery.
Yeah, it's very near. So kita buat GA, selalu GA.